Assalamu alaikum. Today in our teach activity we will talk about the management of hypoxemia, specifically about pulmonary hypertension. This lecture is supervised by Dr. Imam Badran and presented by me, Noor Ghanem. We'll start our lecture by talking about some important points about the oxygenation of the baby. The first point is to talk about the acceptable physiological target oxygen saturation, which is not the same for all babies, but it's variable according to the clinical condition of the baby. So the accepted SAT is between 90 to 95% in full-term babies and in babies with pulmonary hypertension. But it's between 85 to 90% in babies with significant right to left shunt, and between 88 to 92% in preterm babies, because in preterm we are very concerned about the retinopathy prematurity. So that we don't need a higher autosat higher than 92%, and we don't need to increase the FiO2 and increase the risk of retinopathy of prematurity. So in hypoxemia due to right to left shunt, the autosat is limited to 80 to 90% and does not improve with higher FiO2, and we don't need to increase the FiO2 as the autosat will not be improved more than 90% in babies with significant right to left shunt. In babies with hypoxemia due to VQ mismatch, the priority is to recruit the lung by optimizing the PEEP. So the applied pressure to recruit the collapsed lung, it should be enough to overcome the lung compliance and recruit the lung volume, regardless how much is the pressure we need to recruit the functional residual capacity. And this is the simple diaphragm to show the chest cavity, and this is the alveoli surrounded by perfusing arteriole, and this is the esophagus, and inside the esophagus is a probe to measure the transpulmonary pressure. The transpulmonary pressure is the pressure or the difference between the pressure inside the lung and the pressure outside the lung. To inflate the lung and recruit the lung to its proper volume for a proper gas exchange and proper ventilation, we need to apply a pressure equal to this transpulmonary pressure. So if to assume the transpulmonary pressure of 10, we need to apply a pressure of 10 to get a proper inflation of the alveoli and a proper ventilation and gas exchange. But if we apply a pressure, let's say 7, which is less than the transpulmonary pressure, so the alveoli will be not inflated enough and not recruited enough and will be collapsed, and this will affect the gas exchange and the ventilation. If we apply a pressure higher than the transpulmonary pressure, let's say 20, the alveoli will be hyperinflated, and the hyperinflated alveoli will affect the perfusion in the arteries surrounded this alveoli, and this will affect the autosaturation and the blood pressure. So how do we know we are not applying the pressure higher or lower than the needed? Is by continuous monitoring of the vitals, of the autosat, and the blood pressure. If we are hyperinflating the alveoli, the perfusion will be affected and the blood pressure and the autosat will be affected. If we are applying less pressure and the lung not recruited enough, so the alveoli will be collapsed and there will be no gas exchange, and this will affect the oxygenation. So we have to keep a continuous monitoring to guide us in the treatment. So monitoring is very important to guide the management, and the stepwise increase of the PEEP with the continuous monitoring is the key in the management. If we applied high pressure and the lungs become hyperinflated, the infant will not improve, and this will affect the blood pressure and the oxygenation of the baby. So the most important step in the management is a continuous monitoring to guide us if to increase the pressure or to decrease the pressure according to the clinical situation of the baby. Now let's talk about the pulmonary hypertension. The objective of our lecture is to talk about the physiology of pulmonary hypertension, assessment of pulmonary hypertension, and management of pulmonary hypertension. So, the physiology of pulmonary hypertension occurs with three different mechanisms: either increased pulmonary blood flow or increased pulmonary vascular resistance, which is the most common cause, or increased pulmonary venous pressure. These three mechanisms will affect the pressure and increase the pulmonary blood pressure. Before talking about the assessment of pulmonary hypertension, let's talk about the circulatory changes after fetal life. This is a simple diaphragm showing the blue line, which is the pulmonary vascular resistance. The green line is the pulmonary blood flow, and the yellow line is the pulmonary vascular pressure. So during fetal life, the resistance is very high, and the pressure, because the resistance is very high, so the pressure is very high, and the pulmonary blood flow is low as the pressure and the resistance is very high. After birth, the resistance will gradually decrease over days to 5 weeks, and so because the resistance is decreasing, the pressure will be decreased and the pulmonary blood flow will increase. So during fetal life, the pulmonary resistance is high and the pulmonary blood flow is low. After birth, the resistance decreased gradually and the flow increased. This is another diaphragm to show the most susceptible gestation age for development of pulmonary hypertension. This is a diaphragm. The blue line is the pulmonary vascular resistance. The red line is the systemic vascular resistance, and this is before birth, and this is after birth. As we see, the pulmonary vascular resistance is very high in two extreme gestational ages: the extreme prematurity below 20 weeks and toward the term and post-term babies. But in period around 30 weeks, the pulmonary vascular resistance is lower than term and preterms. So we don't expect to develop pulmonary hypertension in this period, around the gestation age of 30 weeks. After birth, the pulmonary vascular resistance will gradually decrease over days to weeks. Regarding systemic vascular resistance, it will increase gradually during fetal life, but a sudden rise after birth and after removal of placenta. There will be a sudden rise of systemic vascular resistance. So pulmonary vascular resistance is very high in extreme preterm and in term and post-term babies, and period in between around 30 weeks not expected to have high pulmonary pressure. Now we will talk about the types of pulmonary hypertension in neonates. The types is related to the physiology of pulmonary hypertension. As we said, the resistance, the venous pressure, and the blood flow. The most common cause is increased vascular resistance. So the first three types is related to the vascular resistance. The first type is hypoxic vasoconstriction related to high pulmonary vascular resistance. The second type is abnormal vasoconstriction due to abnormal capillary bed, like in alveolar capillary dysplasia. And the third type is pulmonary vascular hypoplasia, as in babies with congenital diaphragmatic hernia or in babies with oligohydramnios. So these three types is related to the resistant. But in the fourth type is related to the increased blood flow through pulmonary arteries in babies with congenital heart disease with left to right shunt. So the pulmonary flow will increase, and this will increase the pulmonary blood pressure. The fourth type is related to the pulmonary venous pressure in babies with congenital heart disease with left atrial increased pressure. So the left atrial pressure is high. This will affect the venous pressure in the pulmonary vessels and will lead to pulmonary hypertension, as in babies with a problem with the mitral valve or a problem with the aortic valve. This is a simple picture of the fetal circulation. As we know, during fetal circulation, the depends on the fetal circulation depends on foramen ovale and the ductus arteriosus. But if the baby is exposed perinatally to hypoxia and the pulmonary blood pressure is high, so this structure will still open, the foramen ovale and the ductus arteriosus. So in fetal life, as we know, the right ventricle is the dominant. But after birth, the left ventricle is supposed to be the dominant. But in case of pulmonary hypertension, because of high pressure in the pulmonary vessels, the right ventricle will be the dominant one, and this right ventricle will affect the interventricular septum and push the interventricular septum toward the left ventricle, and this will affect the blood outflow through the left ventricle and the cardiac output from the left ventricle. This is a simple diagram to show the effect of high pulmonary vascular resistance on the circulation of the newborn. If we have a high pulmonary vascular resistance, so the pulmonary artery will be high. So high pulmonary artery pressure will lead to shunt through the ductus arteriosus from right to left. So the ductus arteriosus is now open with shunting from the right to left due to high right artery pressure. This pressure will affect the right ventricle, so the right ventricle will be dilated, and now the right ventricle is the dominant ventricle because of high pressure in the right ventricle. So the dilated right ventricle and the high pressure in the right ventricle will push the interventricular septum toward the left ventricle. So now the left ventricle is smaller than the right, and this will affect the cardiac output of the left ventricle and decrease the cardiac output of the left ventricle. And because the right ventricle is dilated, so its annulus is also dilated, will lead to the tricuspid regurg and tricuspid insufficiency. And tricuspid insufficiency will lead to a high pressure to the right atrium, and high pressure to the right atrium will shift the blood through foramen ovale from the right atrium to the left atrium. So from this cartoon, we will have a high pulmonary vascular resistance and high pulmonary blood pressure, an open ductus with right to left shunt, dilated right ventricle with and pushing of the interventricular septum toward the left, low systemic blood flow, and tricuspid insufficiency with shunting of blood from the right atrium to the left atrium through the foramen ovale. So, reason for systemic hypotension with pulmonary hypertension: because of decreased blood flow and low cardiac output, as the dominant dilated right ventricle pushing the left ventricle and compressing its blood flow. And as we know, the hypoxemia is a systemic vasodilator and eventually will lead to systemic hypotension. So the important messages from this is that pulmonary hypertension has multiple pathophysiological categories, can be due to increased resistance or increased flow, as we said. And severe pulmonary hypertension can affect systemic blood flow in severe cases and cause systemic hypotension, and it's more severe in term, post-term, and in extreme preterm babies. So now we will talk about the assessment of pulmonary hypertension. We have to know that pulmonary hypertension is a clinical syndrome. So we need, so to diagnose a baby with pulmonary hypertension, we need multiple items. We need a clinical suspicion, chest X-ray, and echo. Chest X-ray is very important because pulmonary hypertension can be caused by lung pathology or caused by abnormal vascular resistance. So we need to do chest X-ray to rule out the lung pathology, and if we have lung pathology, we have to manage the lung problem before we can treat the pulmonary hypertension. And the most important point is a continuous monitoring, because the continuous monitoring is the key in the management of hypoxemia in newborns. Monitoring of oxygenation, ventilation, and hemodynamics is the key in the management. Clinically, we can suspect the pulmonary hypertension by 2 points. The first one is the differential oxygenation and the difference of autosat between the pre-ductal and post-ductal. So if we have a difference of 5% or more between the pre-ductal and post-ductal, this point will lead us to do a further evaluation to rule out pulmonary hypertension. The second point is to have more than 2 desaturation events in 12 hours. And desaturation is, the definition of desaturation is autosat below 85% for more than 1 minute. Not a transient desaturation, but a desaturation for more than 1 minute, and we need a 3 events in 12 hours. So clinically, differential oxygenation or more than 2 desaturation events, these 2 clinical findings will lead us to do further evaluation to rule out pulmonary hypertension. So this is the first step, by clinical suspicion. The second step is to rule out the lung pathology. As I said, pulmonary hypertension may be caused by lung pathology and may be idiopathic due to vascular problem. So the difference, we can know the difference by some points. In case of pulmonary parenchymal problem, the history will guide us, like babies with meconium aspiration, babies with risk factor of sepsis, pneumonia. But in babies in pulmonary vascular problem, there is nothing or in history related to the lung pathology. The chest X-ray in pulmonary vascular problem is clear, but in the lung problem, opacified. Ventilation and oxygenation is easier in pulmonary vascular problem, but it's very difficult in pulmonary parenchymal problem. Pulmonary pressure is very high in vascular disease, and it's variable in pulmonary parenchymal problem, and ductus is always patent and right to left, as I show you from the previous diagram and previous cartoons. It's always patent and right to left because of high blood pressure in the pulmonary vessels, but it's small and variable in case of pulmonary parenchymal problem. So this is example of chest X-ray of the baby with idiopathic pulmonary hypertension. The lung is clear, and there is no pathology of the lung parenchyma. So the best treatment in this baby is to use the first line management of pulmonary hypertension, which is the nitric oxide. But in this chest X-ray, there is a pattern or opacification goes with respiratory distress syndrome. So we have to manage the respiratory distress syndrome and to recruit the lung enough to manage the pulmonary hypertension. So the key of management in babies with respiratory distress syndrome or babies with meconium aspiration syndrome, like in this chest X-ray, is to recruit the lung and to ventilate the lung well, and then to treat the pulmonary hypertension, because the pulmonary hypertension in these two chest X-ray is related to the lung pathology. So if we treat the lung pathology, the pulmonary hypertension will be improved. But in this first chest X-ray, the lung is clear and there is no pathology in the lung. So we have to treat the pulmonary hypertension by nitric oxide, which is the first line management of pulmonary hypertension. So now we talked about the clinical assessment and the chest X-ray to rule out the lung pathology. Now the echo. Echo, we have some specific marker to diagnose the pulmonary hypertension. But each marker, it has its limitation. So remember the cartoon that I explained before. In case if the blood pressure in the pulmonary artery is increased, so the ductus will be open with the right to left shunt, the right atrium will be dilated, and the tricuspid valve will be insufficient with tricuspid regurg. So the first marker is the tricuspid regurg, and if we measure the tricuspid regurg by a continuous Doppler wave and measure the pressure in the wave, in the Doppler wave, and compare it to the systemic blood pressure, we can say the pressure is less than the systemic blood pressure, or more than the systemic blood pressure, or the same as blood pressure. So according to this classification, we can say this is mild, moderate, or severe pulmonary hypertension. But tricuspid regurg has its limitation as the incompetence of tricuspid valve because of ischemia in babies with hypoxic ischemic encephalopathy. The second marker is the ductus, the open ductus with right to left shunt, and this is the second marker. The third marker is the cross section of the heart. This is the cross section. This is the normal view. The right ventricle is crescent and the left ventricle is rounded because the left ventricle is the dominant. But in case of pulmonary hypertension, the right ventricle is hypertrophied, pushing the interventricular septum toward the left ventricle. So the left ventricle is like D-shaped because the right ventricle push the interventricular septum toward the left ventricle. In case of severe pulmonary hypertension, now the right ventricle is larger than the left ventricle, and the left ventricle is semilunar in shape. So this is severe pulmonary hypertension because the right ventricle is larger and is the dominant, and this is a suprasystemic pulmonary hypertension. So targeted in neonatal echo pulmonary hypertension, we need a different marker. We can't diagnose pulmonary hypertension from a single marker from the echo, but we need more than one marker. So we classify it as pulmonary hypertension with normal right cardiac performance. The first marker is tricuspid regurg jet to Doppler more than 2/3 of systemic to, as I said, to convert the tricuspid jet in the Doppler wave to compare this jet pressure to systemic blood pressure, if it is the same of systemic blood pressure or more than systemic blood pressure. So the marker is to have a tricuspid regurg jet Doppler more than 2/3 of the systemic blood pressure. The interventricular septum flat or both to the left. The BDA is bidirectional or right to left. Dilated right ventricle more than the left ventricle, or to have pulmonary hypertension with right ventricular dysfunction or low contractility. So classification is to compare the pulmonary hypertension to the systemic blood pressure. Mild is 2/3 of systemic, moderate close or equal to systemic, but in severe is suprasystemic or with right ventricular dysfunction and low contractility. So the diagnosis of pulmonary hypertension is clinical syndrome. We need a clinical suspicion. We need a chest x-ray to rule out pulmonary problem. We need more than one echo marker, and we need a continuous monitoring. So the treatment, to start the treatment by supportive care, optimal temperature, nutritional support, avoidance of stress, and handling with sedation and analgesia as needed. So management of pulmonary hypertension secondary to lung disease should start with lung recruitment and to treat the lung pathology first. In case of pulmonary hypertension due to vascular problem, the nitrous oxide is more effective and it's the first line treatment. So the first line treatment to treat the pulmonary hypertension due to vascular problem is nitric oxide. If there is no response to nitrous oxide, we need to evaluate more. The causes of unresponsiveness is wrong diagnosis. This is not pulmonary hypertension, so we need to evaluate more to know the cause of this and to change the management plan. Or if there is untreated other causes of hypoxemia like suboptimal lung inflation, so we need to optimize the lung volume. Or if there is high mean airway pressure, we need to wean mean airway pressure. Or if there is compromised systemic blood flow, let's say caused by low preload, we need a cautious bolus administration, or hypotension or vasodilator shock, so we need to improve the blood pressure by using vasopressin, or impaired myocardial contractility like right ventricle or both ventricle. So we need to optimize the ventricular function before to improve the pulmonary hypertension by using dobutamine or milrinone if the baby is normotensive, because the milrinone is contraindicated in hypotensive patient because one of its side effects is hypotension, or if the baby is hypotensive, to use epinephrine. So these drugs is to optimize the ventricular contractility, and if we improve the contractility of the ventricle and the function of the heart, we can improve the pulmonary hypertension. But if the baby, despite all these measures, is not improved, so we need to use other measures like open the ductus arteriosus by prostatin or using other vasodilator. So this is a simple diagram to summarize all the management plan. So if we have a clinical pulmonary hypertension, as I said, because of desaturation or differential desaturation, we will start by the first line of management, which is the inhaled nitric oxide. If the baby is responsive, this is good, so we keep monitoring of the baby until we can wean the nitrous oxide. But if the baby is not responsive to inhaled nitric oxide, we need to do more evaluation and to change our management plan. So we have to do a detailed echo. If the baby has low preload, we need to give a fluid bolus. Plus, if the baby had have right ventricular dysfunction, we have to optimize the right ventricle contractility to improve the pulmonary hypertension. If the dysfunction and the baby is hypotensive, we have to use vasopressin to improve the blood pressure and to improve contractility. If the baby have normal blood pressure, we can use milrinone or dobutamine. So then we have to re-evaluate by echo. If the baby improved, we can keep monitoring and wean the drug gradually. But if the baby, despite the inotrope and despite the medication to improve the contractility, is not improving, so we have to use other measures like using prostaglandin to keep the ductus open. But if the baby is not improving, so we need to do an ECMO to improve the oxygenation and ventilation. But don't forget one pathology which is not diagnosed by simple echo. We need to do a CT angio. This pathology is a total anomalous of venous return, which may lead to pulmonary hypertension and can't be diagnosed by simple echo. We need to do CT angio to diagnose a total anomalous pulmonary venous return, and this pathology needs surgical correction. So after surgical correction, the pulmonary hypertension will be improved. And thank you.